To the Zoom meeting. Today we're gonna talk about different topics. The team will start with Dr. Mafaz and her fellows will be presenting some different topics. So welcome.
Good evening, everyone. I am Mafaz Ombada. I'll be the moderator for the day. I'll be representing the refreshing orange team, the oranges. I'll be sharing our agenda for the day. We're going to discuss the interesting vascular and older adults by Dr. El-moez Osman. And then I'll be discussing some facts about vaping and how to improve ADHD during driving. And we'll end it with the project's updates. Dr. El-moez Osman, if you're present, please start sharing your screen and your presentation for the day. Thank you.
Okay, let me share my screen. Hello, guys.
Hello.
Hello, Dr. Nadir. My screen is okay, guys. Can you?
Yes, we can see it.
Okay. So my name is Dr. El-moez. Today I'm very blessed to present a topic about cardiovascular disease. We will start our topic about what is the objective of this presentation. First thing of this presentation, will define how the cardiovascular system change with normal aging. And the second thing is the signs and symptoms of the most important cardiovascular disease in older patients. The third one is the appropriate diagnostic test to identify the presence and severity of cardiovascular disease. Number four is the standard for treating cardiovascular disease. What the topic covered in this section is part one, the epidemiology. Number two is the effect of aging on cardiovascular function. Number three is the cardiovascular risk factors and coronary artery disease, acute coronary syndromes, coronary artery disease. And the part two involve valvular heart disease, cardiac arrhythmias, and peripheral artery disease. So I will start this presentation by defining what is the types of valvular disease. We have four types. Number one, and the most severe form, is the aortic stenosis. Number two is the aortic regurgitation, mitral stenosis, number three, and mitral regurg is the number four. So if we start this topic about valvular disease, we can say that echocardiogram is the procedure of choice to identify the patient have a valvular disease or not. In echo with Doppler, it is a non-invasive access to the cause and severity of most accurate and chronic abnormality in the heart. It is also provide important information about left ventricular size and the function of left ventricle, and also it defines the left atrial size and pulmonary artery pressure and the presence and severity of other valvular disease. In aortic stenosis, the symptoms differ from angina or acute chest pain, heart failure, lightheadedness, pre-syncope, and syncope. On the physical examination of patient presented with aortic stenosis, you can find a mid or late systolic ejection murmur radiating to the carotid. Also, we may find galvanism, S4, and also we can find a left ventricular heave. In EKG, there will be left ventricular hypertrophy. So for aortic stenosis, we have a medical and surgical treatment for this condition. If you go to the medical, it is not effective because, as we said, that for aortic stenosis is a very severe form of this valvular disease. So we'll go for surgical procedures, either percutaneous or surgical intervention. For the percutaneous, we'll go for transcatheter aortic valve replacement. And the surgical option, there is this indicated for a severe form of this aortic stenosis or symptomatic patient with a bioprosthetic valve preferred in older patients. Number two, there is aortic regurgitation. The symptoms of this chronic condition, the patient may be presented with acute or chronic asymptomatic or minimally symptomatic, mild or moderate aortic regurgitation. Also, patient may present with heart failure and angina will be presented in severe cases. Well, what is the finding of aortic regurgitation? The most important thing is increase in pulse pressure. Also, there will be bounding, collapsing pulse in these patients with the diastolic murmur and systolic ejection murmur. In EKG, also there's a left ventricular hypertrophy, severe form, and there is tachycardia in acute presentations. In chest radiograph, we will find cardiomegaly in severe form, and also there may be pulmonary congestion if the patient present acutely with signs and symptoms of pulmonary congestion or heart failure. In the treatment, also there is a medical intervention and surgical. In the medical condition, we can treat it by we can treat the control the hypertension in this patient, preferably with the dihydropyridine calcium channel blocker. Also, we can use ACE inhibitors or angiotensin receptor blocker. Beta blocker in patient with symptomatic or left ventricular systolic dysfunction can be used in this condition. In the surgical option for aortic regurg, this is indicated for acute severe aortic regurg, asymptomatic severe chronic aortic regurg, and asymptomatic severe chronic aortic regurg with left ventricular ejection fraction less than 50%. Also can be used in left ventricular systolic dimension of more or equal to 5 centimeters. This is the dimension of the regurg valve. Number 3, in the valvular disease, we have the mitral stenosis. As we can follow the same sequence, the symptoms of this condition will be gradually worsening, and also there is orthopnea, leg edema, and leg presentation. Patient may be presented with progressive decline in exercise capacity. In the findings, physically, patient will be presented with early diastolic opening snap, which is a low pitch rumbling diastolic murmur at the apex of the heart. And also, patient may be presented with pulmonary hypertension and right heart failure. The treatment, medically, we can use diuretic for volume overload and beta blocker for decreased exercise tolerance associated with tachycardia. In the percutaneous intervention, we can use balloon valvuloplasty, safe and effective in this patient, but most older patients are not good candidates for this procedure. So we can go for the surgical, which is effective, but with 5% to 15% operative mortality in older patients. For mitral regurg, the symptoms can be acute or chronic. Patient can be presented with shortness of breath or somnia and acute condition. Severe mitral regurg, patient can be presented with progressive orthopnea or as in chronic mitral regurg. Findings in physical examination of patient with mitral regurg, there is pulmonary rales. Patient also can be presented with tachycardia, narrow pulse pressure. They may be S3 and short, harsh systolic murmur in acute mitral regurg. Also, they may be hollow systolic murmur radiating to the axilla, and they will be also S3 and pulmonary hypertension and right heart failure in chronic severe mitral regurg. Well, what is the treatment of mitral regurg? First things, as we said in the previous topics, we can start with the medical. A medical therapy for this patient as for heart failure with systolic dysfunction in patient with symptomatic chronic mitral regurg with left ventricular ejection fraction less than 60% who are not candidate for intervention. So for this patient who has ejection fraction of more than 60% and not candidate for intervention, we can go to the surgical options, which include transcatheter mitral repair for selected patient. The surgical option, we have mitral valve repair preferred over the repair, which she can use bioprosthetic valve preferred over the mechanical in older patient. All effective is 5% to 15% operative mortality in older patient. This mortality is lower for repair than the replacement. The surgical option is indicated in which condition? Number one, for urgent patient for acute severe mitral regurg associated with heart failure, and also in symptomatic patient with severe chronic mitral regurg with left ventricular ejection fraction more than 30%. Also in asymptomatic patient with severe regurg chronic with ejection fraction 30% to 60%, and or left ventricular insystolic dimension of the valve for more than or equal to 4 centimeter. The third option or the fourth option here, we have mitral valve repair likely to be successful in asymptomatic. In asymptomatic, this is most important. In asymptomatic patient, for symptomatic patient, as we said, that it is severe condition, better to be replaced surgically. But is in this condition with asymptomatic patient with severe chronic mitral regurg and ejection fraction is more than 60%, we can go for the option of mitral repair. In patient with severe chronic mitral regurg with pulmonary artery systolic pressure of more than 50 millimeter mercury or new onset atrial fib with high likelihood of successful mitral valve repair. So after that, we can go ahead and see what is the transcatheter aortic valve replacement or TAVR. The TAVR with the bioprosthetic is associated with improved outcome relative to medical therapy. This is the second option, as we said. If we started with the medical,
Excuse me, Dr. Maz, we cannot hear you. Dr. Maz, we seem to not be hearing your presentation.
It seems we lost the connection with the speaker. So Mafaz, can you text him?
I did message him, but the message he did not see it. But can you unscreen his screen so we can move to the second agenda if that's possible?
So, Dr. Mafaz, did you get in contact with Dr. El-moez?
Yes, I contacted Dr. El-moez. He's going to try to share his screen again.
Okay. The other option is to, if he has his voice, we can try to use the presentation from a different screen.
Sorry, guys. My voice is clear now?
Yes, it's clear.
Okay, I'm sorry for this technical issues.
No, it's
So
okay.
I will go ahead and see what to stop. Yeah, it is okay. Yes, I am. There's two slides, so I can repeat that. So I think the next topic will be about effective endocarditis, as
Yes,
we said.
Dr. El-moez, we need you to share your screen. If that's
Okay, okay,
yes.
okay. Is it okay now, doctor? Hello.
Yes, we can see the screen. Yes.
Okay. So, by definition, infective endocarditis is the most commonly caused by either Streptococcus viridans or Staphylococcus aureus. But in older patients, we can find another species as enterococcal species or gram-negative. Endocarditis is very difficult to be diagnosed in older patients due to in elderly patients there is less common fever and leukocytosis. Also, the sensitivity of thoracic echocardiography is decreased due to increased calcification in the valve. And also, there is a transesophageal echocardiogram improve diagnostic help for infective endocarditis. What is the treatment of infective endocarditis? We can go ahead and cover the patient with intravenous antibiotic therapy for 2 to 6 weeks. If this antibiotic therapy covering is failed, so the next option will be surgically. But there is other indication for surgical therapy for this for other patient, like if there is a presence of severe valvular dysfunction. Number two, if there is evidence of persistent infection despite antibiotic covering. Number three, if there is a history of recurrent emboli, or the patient may be presented acutely with heart failure. In this condition, we can go to the option of surgery. And also the number fifth option, if the patient they develop myocardial abscess, also in patient with high degree AV block, or vegetation presented to more than 1 centimeter in diameter on left side valve, or in the fungal endocarditis. Recommendation for preventing endocarditis after dental procedure focus on providing prophylaxis only in high-risk patients, and this patient with prosthetic valve or have developed before endocarditis, or in certain condition of congenital heart disease or in transplanted hearts. Recent guidelines have limited recommendation for prophylaxis for those undergoing genitourinary or GIT procedures. We cannot use uh, antibiotic for this patient. The next topic we will discuss about cardiac arrhythmias. Age-related change in the cardiac dysfunction coupled with increased prevalence of cardiovascular disease as older patient at older age, progressively increase in the incidence and prevalence of conduction abnormality and heart rhythm disturbance in older patients. Also, there is age-related degenerative change in and around the SA and AV nodes, which increase the prevalence of bradyarrhythmias in advanced age. Now we can talk about the most important arrhythmias, which is AFib, which is the most common sustained arrhythmia seen in clinical practice. The incidence and prevalence increase potentially with age, such as the prevalence in octogenarians in approximately 10%. Among older patients with valvular heart disease or heart failure, the prevalence is even higher, approaching about 30% of the cases. What is the clinical feature and diagnosis of AFib? Symptoms related to AFib are highly variable. Some patients might be presented with palpitation. Some of them will be presented with shortness of breath or impaired or exercise tolerance. Or some patients can be presented with all these symptoms. In patients with ongoing AFib, the standard EKG is diagnostic. But we can go ahead and do other procedures such as echo, serum electrolyte, because this electrolyte disturbance can cause AFib, like especially in potassium and magnesium. And also we can do thyroid function test, as thyrotoxicosis can be a precipitating factor for AFib. Further evaluation in selected cases may include chest X-ray, cardiac biomarker proteins, and BNA, peptide, and D-dimer level, and lower extremity venous Doppler studies, and evaluation for pulmonary embolism. What is the management of AFib? Objectives include relieving symptoms and minimize the risk of thromboembolic event, particularly stroke. So it is easy, I think, if we can divide the patient to acute, if they presented in less than 48 hours of chronic if presented for more than 48 hours. But as to make it simple, it is principal strategy for relieving symptoms: control the heart rate or maintain the normal sinus rhythm. So we have rate control and rhythm control. Patients who experience a significant shortness of breath and fatigue and exercise intolerance to AFib may be best managed with antiarrhythmic therapy and to maintain the sinus rhythm. Alternatively to antiarrhythmia, to maintain the sinus rhythm, we can use catheter ablation of the anti-thymogenic foci, usually through pulmonary vein isolation. Also, there is surgical means procedure. All older patients with paroxysmal or persistent AFib requires consideration for stroke prophylaxis. The stroke prophylaxis, there is strategies which is called SHA2 VASC. This more accurate than SHA2 or identify the lower risk of stroke. 2 points for age more than 75. For any patient of more than 75 years or equal, it is we can give him 2 points. Patient from 65 to 74 years, we can give him 1 point. Any patient with cardiovascular disease, 1 point. Any female can be given 1 point. So a score of more than 2, in this condition, patient is candidate for systemic anticoagulation. Has plate scores. This is another type of scores. May be useful tool to promote informed decision making by estimating a patient annual risk of major bleeding. This is another scoring system. The stroke prophylaxis, we can use warfarin titration to maintain an INR of 2-3. So warfarin is very difficult because we have 2 monitors. Aspirin can give 75 milligram or to 325 milligram per day, plus or minus clopidogrel. The active W trial demonstrates the superiority of warfarin to the combination of aspirin and clopidogrel in terms of both risk of ischemic stroke and major bleeding of patients with AFib. A direct oral anticoagulant therapy, as we can see below, for characteristic and dosing of the 4 DOAC available for prevention of cardiovascular event in patient with AFib. For AFib, a patient with elevated CHAD score more than 3, in whom chronic anticoagulation is contraindicated, consideration should be given to percutaneous left atrial appendage closure via the Osman device. So, what is the other supraventricular arrhythmias? We have another type called atrial flutter. There's some feature is the same as AFib, but we can go through atrial flutter by definition, usually occur in older patients with AFib, and both anticoagulation and rate control are similar to that of atrial fibrillation. So the management is the same. Patient with typical atrial flutter that is either symptomatic or refractory to pharmacological rate should be considered for a catheter ablation, as in class 1. Atrial tachycardia and atrial ventricular nodal reentrant tachycardia and multifocal atrial tachycardia, all these three types, there is the underlying condition. And also, we can provide the patient with pharmacotherapy aimed to rate the control or arrhythmias suppressions. In selected patients with recurrent symptomatic episode, antiarrhythmias or catheter ablation may be considered for such patient. Now we can go ahead and talk about ventricular arrhythmias. And this is the most dangerous conditions. Frequent ventricular premature beats, ventricular couples, and short runs of non-sustained less than 30 seconds, because we have two types, sustained and non-sustained. Non-sustained, it is less than 30 seconds, and sustained ventricular tachycardia is more than 30 seconds. Ventricular tachycardia. There is no therapy unless highly symptomatic. For asymptomatic patient, we can no need to use any treatment. Treatment only for those highly symptomatic, and in which case we can use beta blocker. Longer episode of ventricular tachycardia with dizziness or syncope, as we said that it is symptomatic ventricular tachycardia. Refers the patient to cardiologist or electrophysiologist for consideration of antiarrhythmias drug or catheter ablation or implantation of cardiac defibrillator for secondary prevention. So the treatment may be medically, or we can consider catheter ablation according to the cardiologist, or we can go ahead and do a cardiac defibrillator for these patients, symptomatic patients. Bradyarrhythmias, by definition, if the patient to go with to bradycardia, if the heart rate is between 50 or 60 or less than 60 beat per minute, in this patient, my bile bradycardia, where the patient will be asymptomatic. In this patient, we no need for any treatment. Patient with moderate or marked bradycardia, resting heart rate between 40 and 50 beats per minute. This patient may present with fatigue, lightheadedness, especially when standing, or reduced exercise tolerance. Syncope or syncope may occur in patients with profound bradycardia if their heart rate is less than 40, or asystolic pulse more than 3 seconds, when due to sinus node dysfunction or heart block within the AV node or infranodal conduction system. How we can diagnose bradycardia? The first thing, we have to exclude significant electrolyte abnormalities, and also we can measure the thyroid function. We can do thyroid function test to exclude the hypothyroidism. And also we can the first step, I think, that we can review the medication of the patient. If the patient is using beta blockers or calcium channel blockers for a long time, this might be cause bradycardia. So the first step, we have to adjust and see and review the patient medication. After that, we can go and check the patient electrolytes, measure the thyroid function test. Number 2, unexplained syncope or syncope, carotid sinus massage in this condition to evaluate for carotid hypersensitivity. An abnormal response to carotid massage is defined as vocal reproduction of the patient's symptom like syncope or asystole more than 3 seconds, or decrease in systolic blood pressure of more than 50 millimeter mercury. If symptomatic occur daily or mostly every day, 24 for 48 hours ambulatory monitors Holter may be helpful for confirming the diagnosis of bradycardia. In patients whose symptoms occur at least one per month, but not daily, we can monitor him for 1 month, might provide the diagnosis. In patients with rare but recurrent symptoms of serious nature, syncope with injury, an implanted loop recorder may be considered. So The diagnosis differ according to the patient situation. What is the management of bradyarrhythmias? Correct and treat the underlying cause. If the patient is hypothyroidism, we can give him thyroxine. And also, if there is any electrolyte disturbance, we can manage the electrolytes. In patients with confirmed symptomatic bradycardia, not amenable to conservative management, we can go to permanent pacemaker implantation. The next topic is a peripheral artery disease disorders, which include abdominal aorta, renal and mesenteric arteries, and iliofemoral popliteal artery 3. Prevalence increases with age and is higher in men than in women. Risk factors include hypertension, diabetes, smoking, and to a lesser extent, older adults and family history. Peripheral artery disease diagnosis. 50% of these patients with peripheral artery disease are asymptomatic or their symptom to another disorders. Formal history and physical examination to screen for symptomatic and sign of peripheral artery disease is recommended for patient 50 to 69 years with risk factor for atherosclerosis, patient of more than 70 years old with or without risk factor. Men above 60 with a family history of abdominal aorta, and men 65 to 75 years who have a smoking history should undergo abdominal ultrasound to screen for abdominal aorta aneurysm. Treatment of peripheral artery disease. The first option we have, it is aspirin 75 to 325 milligram. Also, clopidogrel is recommended as a reasonable alternative to aspirin in selected patients. We can combine both aspirin and clopidogrel in patients with high risk of vascular event and with low risk of bleeding. ACE inhibitor or ARB for prevention of severe cardiovascular event is reasonable in patients with symptomatic peripheral artery disease. Patients with leg peripheral artery disease should do exercise regularly. Revascularization is indicated for patients with severe symptoms of peripheral artery disease that have not responded to aggressive risk factor modification or exercise or the pharmacotherapy. Revascularization is also indicated for patients with critical limb ischemia defined as rest pain, ulceration, or patient has a gangrene. In this context, revascularization have been shown not only to improve symptoms, but also to reduce the likelihood of subsequent amputation. In management, the indication of abdominal aortic aneurysm repair, number one, develop symptomatic patient, or if there is a rapid aneurysmal dilatation, which can be detected by regular ultrasound during serial assessment, if the diameter is more than 1 centimeter in 1 year, or aneurysm is more than 5.5 centimeter in diameter. If the size is more than 5.5 centimeter from first time, we can go ahead and do repair. Patient with asymptomatic aneurysm 4 to 5.4 centimeter in diameter should undergo repeat evaluation at interval of 6 to 12 months, either half a year and 1 year annually. Choice of open or endovascular surgical repair of aneurysm is based on location of the lesion and patient comorbidities and prognosis. In summary, calcified aortic stenosis is the most common valvular abnormality requiring intervention. Is the standard treatment as treatment for healthy older adult, while transcutaneous repair is an effective alternative in older patients. Atrial fibrillation increases in prevalence with age, and more than 50% of all patients with AFib are age 25 years or older. Most older patients with AFib respond to rate control medication and antiarrhythmic medication, but some require antiarrhythmic therapy or other intervention. If the patient presented unstably, we can go to and give him this shock. The prevalence of peripheral artery disease, as we said, that increases progressively with age, and is a potent risk factor marker for concomitant cardiovascular disease and cerebrovascular disease. Management should be appropriate for treatment for hypertension, dyslipidemia, diabetes, and tobacco abuse in accordance with the existing practice guidelines. We can go ahead and see case number 1. An 82 years old man have been progressively shortness of breath with exertion over the past several months. He had been healthy throughout his life with no risk factor for cardiovascular disease. On examination, this patient's hemodynamic findings are normal at rest, with no postural change in blood pressure. Jugular veins are distended 6 centimeters. They are bilateral pulmonary curricles. There is a pedal edema, but no calf pain or swelling. The question, which one of the following should be ordered first for this patient? Choice number A, spiral CT of the chest, transthoracic echocardiography, pharmacological stress test. Number 4, complete blood count. You can give 30 seconds for the answer. So answer of this question is transthoracic echocardiography. Case number 2, 84 years old woman come for routine visit. She is concerned about the number of medications she takes, polypharmacy, and asks why she need to take preventive medication for cardiovascular disease at her age. She had a small non-STEMI 12 years ago, but no cardiac symptoms since that time. Medication included amlodipine, atorvastatin, metoprolol, metformin, acetaminophen, and aspirin. She usually walk up and down her block every day, regular exercise. She had been missing this walk more frequently because of fatigue. Examination, blood pressure is 130/80, heart rate is 60. Recent labs show hemoglobin A1C 7.5%, LDL cholesterol 80 milligram per deciliter. The question, which one of the following is the most reasonable recommendation for this patient? Choice number 1, stop aspirin and atorvastatin. Choice number 2, stop metformin. Choice number 3, stop amlodipine and metoprolol. Choice number 4, resume for regular walking program. You can give 30 seconds for the answer. The answer of this question is to resume her regular walking program. Case number 3, 88 years old man come to the office for a consultation. He had progressive shortness of breath and exertion. He has recently had chest pain and dizziness when he walks. His surgeon says that he has to refer for surgery, but might be a good candidate for catheter aortic valve replacement. Which one of the following should be considered in the management plan for this patient? Number 1, transcatheter valve replacement might be less effective for patients who has concomitant mitral regurg and pulmonary hypertension. Number 2, gait speed less than 0.3 milli per second can be used to identify patients who will not benefit from this repair. Number 3, patients with normal Holstein score are more likely to benefit from this repair. Number 4, risk score that incorporate medical measures are more useful for this patient who that incorporate frailty measures. We can give 30 seconds. So the answer of this question is number A, that the repair may be less effective for patient who has concomitant mitral regurg and pulmonary hypertension. Thank you so much, guys. If any question, I'm here.
Okay, thank you very much, Dr. Naz. Seems like there's no questions. Thank you for presenting a very excellent job in this presentation, and thank you for volunteering to present today.
You are welcome, doctor. Thank you.
You can enter your screen now, Dr. Naz. Thank you very much. We'll be now moving to the other second agenda, discussing what do we know or what should we know about vaping. It will be presented by me, Mafaz Ombada from the Orange team. I'll be discussing the original story about vaping, how does it work, the e-liquid that it uses and its content, its effect versus the safety of vaping, who is at risk during vaping, and some screening tools and some exercise at the end. So when we think about when it started, e-cigarettes are fairly new to the US market. It was introduced in 2007 and it became very popular around 2014 among the youth in the US. How it works is that it produces an aerosol by heating liquid that usually contains nicotine, and which is a addictive drug in regular cigarettes, cigars, and other tobacco products, using other flavors and other chemicals that can help in making the aerosol. As I mentioned, e-cigarettes or vaping, it has different names such as e-cigs, e-hookahs, modes, vape pens, vapes, tank system, and electronic nicotine delivery system or ENDS. On the left side, we see what a regular cigarette looks like, but we need to be more familiar with what a e-cigarette looks like. So on the right side, we see what a disposable e-cigarette is, and it resembles a flash drive in shape, and it comes pre-filled with an e-liquid. And we'll be discussing what an e-liquid is and what its content is in the coming slides. And in the middle, we see what a rechargeable e-cigarette looks like, and they come in various shapes and sizes. Some may resemble a form of rubber or a flash drive, and these type can be refilled using an e-liquid. Moving on to the tanks and modes, and such a device will be called a vape pen, while the one in the middle is a mode, and the larger one is a tank, and they can all be refilled using an e-liquid. Before moving to what an e-liquid is, I would like to speak more about the similar device called a heated tobacco product, which is very new to the US market currently. And this heated tobacco product uses heat to actually heat tobacco leaves, in contrast to e-cigarettes, which uses heat to heat the liquid or e-liquid that contains nicotine and other flavoring and other ingredients. As I mentioned, it is still new to the US and it is not FDA approved as a method for quitting smoking. Studies has shown that secondhand emission from heated tobacco products suggest that the products expose both users and bystanders to some of the same chemicals found in cigarette smokes, although at a lower level than cigarette smokes. And as of February 2022, the FDA has authorized only one form of heated tobacco product, and that is the IQOS system. And this is what I have shown in the right side. The IQOS has a more sophisticated look to it and more futuristic, and this has made it more popular among older adults rather than the younger adults with e-cigarettes. So in a study done in 2018 showed that 2.44% of adults, including 6.7% of people who currently smoked regular cigarettes, reported to the CDC that they had ever used a heated tobacco product. In comparison to a very recent one in 2023, showed that 1% of US middle and high school students combined reported having used heated tobacco products in the past 30 days. So we're seeing that it's becoming more popular among the older adults as well as the younger adults, such a heated tobacco product. Moving on to the e-liquids. E-liquids is the liquid used to For inside the chamber in the e-cigarette itself, has different names. It can be called an e-liquid, can be called an e-juice or a vaping juice. Its content has usually tobacco or nicotine. It has propylene glycol, vegetable glycerin or glycerol, and other chemicals, which is usually the flavoring, and in some cases it contains water. So as we see, it has very inviting, colorful, and very flavor content in very various choices that has even percentage of nicotine to be chosen from. So with such a various choices, it has the nicotine, it has the flavoring, it can have some heavy metals such as nickel, tin, and lead. So with such flavor system that it has provided, it can be tempting for users that have never smoked to pick up on it as it's very inviting. And therefore, some laws were pushed up against it, such as the FDA on the 2nd of January 2020 finalized and enforced a policy that prohibits the sale of pre-filled cartridge e-cigarettes in any flavor other than tobacco or menthol, which is mint, unless it is authorized by the FDA. Another law that has been pushed is the Tobacco 21 or T21, which prohibits the sale of tobacco products to any person under the age of 21. What are the effects of vaping? This can be divided into effects from the e-liquid and its content and a device malfunction of the e-cigarette device. So looking at what the e-liquid can cause, and mostly comes from the nicotine content. And as we know, it is highly addictive. It is toxic to developing fetuses and can be harmful to the adolescent and young brain that is still developing, which continues to develop into the early mid-20s. Nicotine is also harmful to pregnant adults and their developing babies. In addition, acute nicotine exposure can be toxic, as we're speaking of a nicotine in its liquid form. So children and adults have been poisoned by swallowing, breathing, or absorbing e-cigarette liquid through their skin or eyes. Device malfunction, which is unintended injuries, as the e-cigarette batteries have caused fires and explosions in the past, which have some caused serious injuries. So most of the reported explosions have happened when the e-cigarette batteries were being charged. With any new device or um, ingredient that we introduce into our bodies, there are some conditions that can arise. And this condition, when speaking about vaping, is EVALI. EVALI, which stands for e-cigarette or vaping-associated lung injury, has been reported in vape users with close relation to vapes containing THC or cannabinoid product. The symptoms include shortness of breath, coughs, chest pain, very labored breathing, abdominal pain, and diarrhea, which is a plethora of symptoms, all of which increase the suspicion of possible lung infection. Therefore, physicians started investigating with chest x-rays at first, and we saw hazy-looking spots or opacities in the lungs, and a bronchoalveolar lavage was done showing high levels of vitamin E acetate, which was only found in vapors' lungs, with the exclusion of other bacterial and viral infection in organisms. When it comes to diagnosis is by exclusion, and treatment, it includes corticosteroids that reduce inflammation in the lungs and throughout the body, supportive care, supplemental oxygen through nasal cannula, and more severe cases will need more mechanical ventilation. In addition to antibiotics and antiviral medication, which can be used in the early stages of diagnosis until the diagnosis is finalized, as EVALI it can be difficult to distinguish EVALI from bacterial and viral infections, especially during the influenza seasons. Is it safe? Is vaping safer than e-cigarettes, or is it safer than regular cigarettes or the heated tobacco products? Well, the answer is yes, it is safer than traditional cigarettes, but that does not mean that e-cigarettes are safe, as e-cigarette aerosol generally contains fewer toxic chemicals than the deadly mix of 7,000 chemicals in smoke from regular cigarettes. However, E-cigarette aerosol is not harmless. It can contain harmful and potentially harmful substances, including nicotine, heavy metals like lead, volatile organic compounds, and other carcinogenic agents. It is currently not approved by the FDA as a quit smoking aid. However, cigarette can be helpful in non-pregnant adults who smoke if used as a complete substitution for all cigarette-containing products or tobacco products as a mean of cessation of smoking. Who is at risk? Looking at the reports from 2019, among adults who currently used e-cigarette overall, we saw that 36.9% also currently smoke cigarettes, with 39.5% formerly smoked cigarettes but are currently smoking e-cigarettes, and 23.6% have never smoked cigarettes before. Comparing it with the most current one in 2023, we saw a 2.13 million US middle and high school students used e-cigarette in the past 30 days, including 4.6% of middle school students and 10% of high school students. So it is a very growing industry and very becoming more popular among the youngsters, the vaping process. How do we ask about the vaping habit during our social history taking? As we are very familiar with asking about cigarette smokes and alcohol use. However, using the wrong terminology or the unpopular terminology of cigarettes or smoking can be less detailed when it's coming to discussing it with a patient that's vaping. So using the right terminology such as e-cigarette or e-cigs or e-hookahs or modes, vapes or vape pens can help us understand more what the patient is using or not. Also, keeping an eye for vape bands around the neck as it's becoming more popular among users to wear it around their neck. We can see a vape pen over here or an e-cigarette or a mode system being worn around the neck. Some of the screening tools that's used or it's recommended by the Stanford is the CRAFT-N and the SBIRT. The CRAFT-N has two evaluation systems, the self-administered and clinician-administered. We can take a look at the clinician-administered. The clinician-administered has or gives us a look for the past 12 months habit of the patient. It looks into the alcohol use, the marijuana use, any else being high or using other illegal drugs, and looks into the vaping process or vaping usage. What does CRAFT stand for? So CRAFT stands for have you ever ridden in a car driven by someone who was high or has been using alcohol or drugs? R is for relax. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? A stands for alone. Do you ever use alcohol or drugs while you are by yourself or alone? F is for forget. Do you ever forget things you did while using alcohol or not, or drugs? And the other F stands for do your family or friends ever tell you that you should cut down on your drinking or drug use? And the last T stands for trouble. Have you ever gotten into trouble while you were using alcohol or drugs? And depending on the answer, we can have a more insight into what the patient is dealing with. And this is a quick exercise that I would like you to either unshare your unmute yourself or write in the chat box how many vapes do you see in this picture? Is it 1? Is it 3, 5, 6, or 8? I see someone said 6, Dr. Saida. Anyone else? Okay, Dr. Najla said 5. Dr. Amma said maybe it's 10. Dr. Amida, 5, and iPad said 3. Well, let's see what's the answer. We have 1, 2, 3, 4, 5, and the sixth one. So it is D. The answer is 6 vapes in the picture. So I just wanted to add this exercise as it's very easy to conceal a vape, as it can have a very stationary look to it, a very normal look to it. So it can be easily concealed. Is there any questions? Perfect. Seems like there's no questions. Thank you guys for listening. And I'll stop sharing my screen now. Okay, thank you very much. Now we can, yes. Let's turn another.
Thank you so much. This is a great presentation. Both of the presentation are great. Thank you so much, both of you. Very informative and up to date. Good. Thank you so much.
We still have another presentation. Yes, we'll be speaking about the improving driving in ADHD. Yes. So our next presentation is about improving driving in ADHD patients. What we'll be discussing is we'll be having a quick look back at what ADHD stands for, its definition, the types of ADHD, the risk factors, how do we diagnose and treat ADHD. And then we'll be having a quick glance into what a typical ADHD patient has as a day, how they spend their day, and what does the challenges look like for them, and how do we improve driving in patients with ADHD. So what is ADHD? It stands for Attention Deficient Hyperactivity Disorder, and it is one of the most common neurodevelopmental disorders. It is described as a pattern of inattention or hyperactivity of at least 6 months or more. It has a male predominance of 5% prevalence. Age onset starts off about 12 years with a risk factor of genetics and environmental. Comorbidities include conduct disorder, oppositional defiant disorder, disruptive mood dysregulation disorder, autism spectrum disorder, and etc. From about 35 to 65% have persistence of ADHD symptoms into adulthood, which can be challenging. Some of the challenges include academics, maintaining relationships with people, poor self-esteem, and increased risk of alcohol and drug abuse. What are the types of ADHD? The first type is predominantly inattentive, which presents as difficulty seeing tasks through, following rules, or conversations. Therefore, they're easily distracted. Second type is predominantly hyperactive impulsive. These are described as impulsive, very active, fidgeting, and talkative people, described easily as a young child that might be jumping around, running, and climbing constantly, interrupting others or speaking inappropriately, prone to more accidents and injuries than the other types. The last type is combined, which has symptoms of both the other two previously mentioned types. How do we diagnose it? We use the two-system method. We use the DSM-5 criteria of inattentive and hyperactivity, the age of onset, the symptoms that presents in 2 or more different settings. The other part of diagnosis is the history. It has to be taken from the parents, the teachers, and the patient themselves. There's also different screening tools that we use, such as the Vanderbilt ADHD Diagnostic Parent Scaling. There is an adult scale, which is the Wender-Utah rating scale for ADHD, and these are all helpful to make the correct diagnosis in ADHD patients. When it comes to treatment, our first-line treatment is amphetamine derivatives, methylphenidate, which is a stimulant which works by increasing activity of a non-competitively blocking reuptake of dopamine and noradrenaline. Some side effects include nausea, vomiting, insomnia, dysphoria, weight loss, and abdominal pain. Some drug interactions include SSRI, MOAI, warfarin, PCA, and phenytoin. It is contraindicated to patients with cardiovascular disease. Second-line therapy includes atomoxetine and guanfacine. When it comes to non-medical approach, it is used simultaneously with medication, which includes psychotherapy, behavioral therapy, parent training and education, social skill training. And also memorable to mention is that there are some researchers that advise using omega-3 and omega-6.
ده ابلكيشن بيوريك الناس مسمياك ايه على الموبايل عندها. يعني انا اكتشفت في ناس مسمياني علي غزلان ستومك.
Yes, so some researchers advise using omega-3 and omega-6 fatty acid as it can be beneficial for patients with ADHD. However, it is worth mentioning that evidence supporting this is very limited. Now we come to the scope into the day of an ADHD patient. I have recently read an article about a ADHD engineer. Her name was Sam, or we'll call her Sam for the day. And Sam mentions that she starts off her day at 10 a.m. as she wakes up freaking out as she was stayed up late the other day, and now she's rushing to meet her client at 11 a.m. So she wakes up, she is picking up and gathering all her project for the day, and she contemplates making her coffee at home or should she pick it up at a near coffee shop. And then her mind drifts off to the clutter in the kitchen, the sink, and how it's messed. And she thinks all of that before picking up with the project and deciding to pick up her coffee in the nearby coffee shop. And as she gets into her car, she starts her engine. She looks into the passenger seat and sees all the paper and reminisces all the projects and what the papers rely and what they detailed in her mind. And then she starts to make her journey to the coffee shop. But however, during the journey from the house to the coffee shop, she is mesmerized by the sky, the grass, the cars in the road, the people in the road, and that's a very part of the that highlights part of the challenges that she has to face, which is the distraction. And as she's making her way to the coffee shop, she ends up changing her direction without realizing and going to meet the client. And she only remembers that she did not get her coffee when she meets her client at the work office. So the most part that we have to discuss with patients with ADHD is that the challenges regarding the distraction is the true challenge, and we should show them empathy and understand that this is a very hard thing to deal with on a daily basis. So when it comes to driving and we add distractions in it, it can be fatal. And driving is a very important part of our daily life. We rely on it to get from places to places. It has become an essential part, not a necessity anymore. So in a recent study that detailed an intervention versus control group program that was done, and it used a computerized skill program focusing on reducing distraction and increasing attention learning versus the enhanced conventional driving process and educational program that's used. So the study outcome included the period of long glances and lane position, collision, and near collision. The results discussed showed that the intervention group had decrease in long glances and decrease in collision and near collision as their distraction has reduced and their attention span has become stellar or has improved during this process and intervention. What are the safety strategies that we can discuss as physicians with our patients? So it's very important to remind them to take their medications as it will help them reduce distractions and keep them safe. When it comes to driving a manual transmission car, never drink and drive, and that is for everyone, in addition to buckling up when in the car. Do you have any questions? Perfect. Thank you guys for listening. This was our last topic for the day, ADHD and driving. We can now move to our last agenda, which is the project updates. And if there's anyone that would like to share, please feel free to unmute yourself. Thank you.
Thank you so much, Mafaz. This is also great presentation. So it's a topic that we discussed in the past and I wanted to discuss. And the idea is to show you guys how you can create some research question and then work on that to build a project or review things or improve things. So this group of people with ADHD, they have trouble with driving. So one of the authors of this study came up with the idea how we can do the study on this group. So they come up with a question and then they wrote a method. We're gonna do this. And then they collected the data and the intervention and the results and they publish it. So any one of you in the future can look at what group you are serving, what group of patients or even normal people around you that have some trouble or some difficulty or some area that can be improved on. And you can put a question, put it in a research format and build a theory about that. So let's say I'm gonna do this to improve this. Then you write your method and you can get some funding. If you have the team, the funds, then you can carry on with your project and you can publish it. Some projects can be just as small as one patient. So if you have some of your patients you are following has some unique things, you can investigate more about this and you can write about how you can improve the life of that patient. Sometimes you can just present that patient as a case presentation. So just think about how you can create some questions around the people that you serve. Thank you so much, Dr. Mafaz. And, thank you, Dr. El-moez, for great presentations. Any questions or any addition, any comments? If not, we can go and discuss the projects, current projects or future projects. Any suggestions, ideas, updates? So this morning I spoke with the person here. The group presented a webinar a few weeks ago about long COVID. So if any one of these presenters or fellows is here. So what Meher was suggesting is that the webinar was great and it has a lot of useful information. Every one of you worked on that. You collected great source like information. So why don't we take it to the next level? So Rayan, if you want to jump in, so the idea is to convert that into a manuscript. So can you share with us?
Assalamu alaikum, Dr.
Alaikum assalam.
Yeah, so kind of like, so when we did our research for the long COVID webinar, I was thinking to do like manuscript, but because it was like we didn't initially do that, I thought it might be a bit more difficult to go backwards. I know right now, so I already formed a group for the pediatric webinar. So the difference between the two is with the long COVID in adults, there was 3 hallmark symptoms that they focused on, and those 3 hallmark symptoms were where we generated the systems from. So with the pediatric, what we're actually going to be working on the manuscript or a systematic review, as well as the webinar simultaneously. So do you think then, should I go back and like get all the resources and try to make a manuscript for the adult COVID? What do you suggest?
I think it's a great idea if you have the manpower, if you have some of the fellows available or not some of the new fellows interested. So what you can do is you can search, see if is there anything similar to this published? If not, I think you can start writing the manuscript and we can see where we can submit it to.
Yeah, there
Which
was
journal?
I did see a few like similar so when we did the webinar, there was systematic reviews on long COVID, but they didn't cover the all three systems. So it might be like a good idea to go back and see that, because I think with ours is because we focused on the three hallmark symptoms, it might be a little bit different as to what was already out there. So I'll reach out to my group, see who's available and who's interested, and then from there we can decide if there's space to add more fellows to join it.
Sure. And for the manuscript, I don't think we have to limit the number, but it depends on who wants to contribute as much.
Okay.
The other point I want to share is even if someone published the long COVID, see what angles they look at the long COVID. So you can look at it from different. So your webinar was focusing on the 3 points of systems, but
Yes.
if you can also subtract and focus on older adults, you might be a unique approach, or the perspective might be different or similar. When you are planning for the pediatric, you can look at if something presented in pediatric or not. If it's not, then it's a unique perspective for all these group, the pediatric group. So
do you mean like as a comparison? So like do a comparison?
No, you don't. No, not comparison. Just
okay.
You are working on this. Let's say there is a published paper about long COVID. So look at that paper from what they cover. If they didn't cover all the adults specifically, then you can modify your manuscript to cover all the adults. So you distinguish yourself from repeating what they are saying, if that makes sense.
Yes, no, that
if
makes a
you
lot
are,
of sense.
If you are focusing on the 3 system, if they focus on the 3 system, then it's gonna be just repeat. So you don't need to go that route. If that.
Okay.
So
my
just
question
make
is
it a little bit unique. Yeah. Go ahead.
Okay. Because subhanAllah, I had, I guess, like in my head, I was thinking, should I initially do a manuscript or should we make it into more like an article, like a review article in a sense? What would you recommend? Should we continue with the manuscript part or should we make it into like a review article? Because it's not necessarily like a research question. I don't know.
No, yeah, you can write it as a review. You can write it as a review. So you already reviewed some of this published data and you collected some of it, right? Or the results of all this. So you want to collect all in one place. So instead for me to look at all these journals to find out about long COVID, if you can just put it in one place for me, that would be great.
No, you're absolutely right.
Subject, for example.
Okay. No, that sounds real good, Dr. Nader. Like you said, we already have all the information. We already have the resources. So I'll reach out to my group and with them, if like for the review article or manuscript, we can potentially add like 3 or 4 more people. I think we only have 6 right now in our group, but yeah, I'll reach out to them and inshallah I'll send you an email to update you. Okay.
Sounds good.
Thank you so much. I appreciate that.
You're welcome. And I'm gonna jump to the next point in a minute, but I'd like to let Haifa go ahead. If you have a question or comment, go ahead.
Yeah, thank you, Dr. Nader and Dr. Rayan, about this article about the long COVID in the pediatrics. So I'm just like a little bit confused. Actually, to be honest, like this is my first time to contribute in such work, but the title or like the concept of the like the work that we're gonna do, it's like a little bit confused for me because like Dr. Rayan mentioned that the one that they did in the adult age group, so it's like they focus on like I think what I was to understand is like 3 main symptoms or something like that. Am I correct?
Um, yeah, so when we initially did our review, so like I can connect with you
Yeah,
afterwards, Dr. Haifa, if you'd
yeah,
like, just so we're not
yeah.
taking up
I'm
time from
so
your. But
excited. I'm trying, yeah, and because I'm trying to like collecting data, but because I
yeah,
don't understand the main concept of the, I mean, I'm just like I'm trying to do my best, but just want to make sure that what you are looking for, so I can help, like
yeah, no worries.
more
I'll
specific. Yeah.
connect with you after the meeting. Like we can
Okay.
quickly jump on a call and
Great.
dissect all the
Great. I
information
really
together.
appreciate it. Jazakallah
No,
khair.
of
Jazakallah
course.
khair. Thank you. Bye bye.
Thank you. Okay.
And just to summarize, Ryan, you've correct me if I'm wrong. But to summarize, the webinar last time was done according to the three system, let's say musculoskeletal neurological system, and what else? And
A
cardiovascular system.
cardiopulmonary.
So they focus the cardiopulmonary system. So they focus on these three areas, and you can go further than that. But this is what the webinar was focusing on. When you talk about next, when you can identify areas. So you can chat and let us know just for the sake of showing others how this is done. Thank you so much.
Yeah, no, absolutely, absolutely. Dr. Nader, the reason why we focus on those three systems, like I'm saying, just to clear it up, is when we initially did our research, like when we did when I initially went on PubMed and Google Scholar and the different journals, I found like it kept mentioning three hallmark symptoms related to the adults. And so those three hallmark symptoms, those were what was related to the systems that we focused on. So it's not to say that long COVID can't be, focused on like the gastrointestinal system, but we noticed that the three symptoms that came up the most were related to what we discussed. But in pediatric, we didn't limit ourselves yet. We're just doing an initial like a research right now just to see if is it the same. So like, are the three symptoms the same in pediatric, or do the pediatric population present with like more GIT systems as opposed to like neurological, right? So I think the different age groups assessment is going to be presented differently. So we're just at the initial stage, but it'll also be a good, comparison between the two.
Sounds good. And before say that, John, I just want to add, if you want to also uh, squeeze this data and see if you can create a poster that can be presented in one of the coming conferences, that would be great. One other idea is to see if it has something to do with pain, because I know the pain conference also is coming in January, the due date of submission
Yeah.
for poster. So we can work on that with some group of different group of fellows if they are interested.
Yeah, no,
Thank you.
that sounds really good because I know with Dr. Naoud and Dr. Amal, when they focus on the musculoskeletal, I think they also discussed about like the relation of pain and fatigue, because a lot of patients, I guess, were uh, diagnosed with like fibromyalgia in a sense because the pain wasn't necessarily related to anything, right? So that's something that we can discuss, and I think that would be really interesting. And we could potentially do a poster on that for sure.
Yeah, sure. So if you or one of your team can look at the pain conference, we contributed in the past to some of the conferences. We can approach them again or different ones. So you see what's the deadline so that you can at least work on the skeleton of the maps and the abstract so you can meet the deadline. I know it's the holidays nowadays, but yeah. Thank you so much.
Thank you, Dr. Nader.
Dr. Saida, go ahead.
Hello, Dr. Nader. I would like
Mhm.
first to thank you and thank you, Dr. Ryan. I recently joined, so I'm not submitted to any group yet, but I'm so interested in the pediatric topic. So as a beginner, I want to ask if there any chance to be added on that topic or no?
Yeah, there's potential to add you, Dr. Saida. So if you just reach out to me, or I can reach out to you and then we can talk, inshallah.
Okay, thank you so much, Dr. Ryan. Thank you, really appreciate it.
Sounds good. Thank you. So, Dr. Note, maybe you can jump in and share with us.
Hi, everyone. I hope everyone is doing good. I think Dr. Ryan also raised a good point, especially for those of us who are either in USA or Canada, or for those of us who have previously presented a poster or research. There is no like rush to add another poster or research into our resume. So I was thinking anyone from the group who is outside the US, maybe this is a good opportunity for them maybe to visit for 3 or 4 days and present it as a poster. So as Dr. Ryan was saying, I will be willing to help in making the poster, but I'm also will be willing to give the opportunity to someone who is outside the US so that they can come here, make connection for the next year or maybe 2-year residency season. So I think our team leader is Dr. Ryan. We can decide whether to make the poster or not. Then after that, we can give the opportunity to someone who haven't presented a poster before, or maybe who is outside the US and willing to travel for about 3 or 4 days.
Sounds good. I think it's a great idea. So you can discuss between you guys, and this platform is just creating connection between you guys, collaboration between you guys, and contributing. Each one of you can contribute a little bit, but when you work as a team, it's gonna have a big effect on you and others. So thank you so much for sharing that note. Great idea. Any other comments, ideas, or updates about your projects, your research, or any question about this program, or any suggestions for this program? I know we have new fellows that some of them are available to jump and contribute and work on. So we want you to understand that. We want you to learn the process. We want you to start from, if you have some experience that well and good, you can just start with the group that you join. If you are a beginner, let's say you know a little bit or some things in the research area, we have the app where you can focus on certain things. So I'm going to just share. So I share the screen here. So in the app itself, when you log in, hopefully you can get into the curriculum, and we divide that into the group or 3, depending on the experience. So you may think you are early in the research domain. So if you have a little bit, some ideas or none at all, we have no problem. So you'll put yourself in this group. If you have some, you know, more, you want to get so advanced, then this is the area for you. And then for those who already had published in the past and had some good research experience, either after medical school or when they came here, or their work type, they get involved in some research opportunities, then they may have some good experience. Or some of you might have PhD or master or some advanced degree in some part of the research. So you might know much better or more than the other 2 groups. So your job is to help these 2 groups to get up to your level, as well as if you want to publish, you will have some of these groups available for you. So you divide some of the little tasks, so you don't have to end up doing the whole work yourself. You know what to do, but if you divide it between the rest of the fellows, you will have plenty of time to get new ideas, maybe run 2 or more projects at the same time, and then you can help publish and help the other group as well. For the ones who are early in the research part, we want you to go over what item of this you need to learn about. So we want you to know something about the ethics of the principle of research, how you do that. So I want you to learn about IRB approval, how you can make sure if you are dealing with humans or even animals or other, then you will go through some steps that prevent harms um, into this group. How you can select a topic, how to create a research question, and so on. So you go one by one, and we have some videos if you want to. If you go to them here, we have some of the videos if you go down that will show you some of these concepts in research. So we want you to do some of that on your own. It's kind of a self-paced learning program. And if you have questions, the fellows and senior fellows can be approached, and anyone of them available to help. When you have a chance, they have a chance. If you have questions, they can. If you can't find any one of the seniors, I'll be happy to guide you through if you have questions or a specific area you want to focus on. And for the seniors, if you think this approach or this categorization and curriculum items need to be updated or improved or added on something that need to be edited, please let me know, because this program is for you guys, and I want it to run by you. So depending on your senior, junior, you have good experience, you have less experience, each one of you can contribute. And so let me know, and I'm here just to help. Thank you so much. Any other comments or any other questions? Please raise your hand or jump in. I'll be happy to share with you or let us know.
Hello, Dr. Nader.
Hello, Dr. Amir. Go ahead.
Yeah, so we are currently working on a mobile application that is called Salama. So it's an emergency educational app for the general population. We are currently working on the App Store version. We asked a developer to develop this for us. We're almost done. And after that, we are going to design the version for the Android ourselves.
Oh, that's good. That's great.
Yeah.
So the developer here in the US or overseas?
I'm not sure about that because I'm not the one who contacted the developer, but I think
Okay.
he's overseas. I think so.
That's fine. That's fine.
Yeah.
That's great. So excellent. Thanks for the update, and let me know if I can be of help. And I would suggest that you start recruiting some of the fellows who have some free they want to participate, so that you can build from now the advertisement team, let's say. So when the app is ready, they already know what to do, and they can share that with you or with others. Thank you.
Yes, that's a great suggestion. I will make that, inshallah. Thank you so much.
How about the other app? Any updates? Other apps? I think there are some group working on the renal, and some of the dentists are working on their dental app. Any ideas? If not, that's fine. Any other questions, comments before we end the meeting so we can end earlier today? Go ahead, Dr. Sayeda.
Yeah, Dr. Nader, sorry for the interruption. And
No, we are here to help, so go ahead.
Just one last question. As recently added a fellow, so I just want to know when exactly it would be submitted to a team to start working in projects.
So the projects you can start right away. If you know one of the team, let's say you started with Dr. Ryan, you can go ahead. So what we do in this program is we divide you into teams so that we can present on this Saturday meeting. It's just organizational kind of group. So each group, they have their opportunity if they are available. I know some of you might be busy with many things. Some of you might do step 3 or working during their day. They may not be available. So the other people who are available, they can help presenting the topic if they are interested and they have time and they want to put that in their resume. The organization part is we divide you into teams. So by colors, let's say the orange team today presented this couple of topics. Next week, it will be a different team, let's say the pink team, for example. And so the team leader from that team, or he can assign someone else. If he or she not available, they can talk about who will moderate the Zoom meeting and who will discuss the topic, who will present these topics. And these topics are listed in the app. So when you go to the app, let's say, when you start on top, you will have the information about the meeting, and then you can look at the next coming Zoom meeting next week, for example, will be the pink team. And this is a topic, and we want to add some of the fellows to this topic. So 1 or 2 or more, they can present one topic. Let's say delirium is a very important topic, but it's very big. So I would like to have, I'm going to just pick some names for here. For example, Dr. Amul Amin, Dr. Fatma, Dr. Nidal, they are interested in this topic and they want to share and present the topic. So they can just hit here and then they can add their name, A, B, C over there. And then when you save that, it will be saved here. Usually the topic will be created from a slide that's presented by the American Geriatric Society. It's a teaching slide, but you can update that information. So the slide might be here. You can look at it, you can update that. Next topic, how to write a letter to the editor, for example. So another group of you, and say that maybe they want to work together in this topic, so they can put their name here, and then they will present AB and so forth. So after you're done, the team leader will say, hey, all of you are ready, then I'll be moderating, similar to what happened today. One will lead the Zoom meeting, and the rest will be presenting the topics, and so on. So the week after team from the purple group will present about other topics and so forth. So this is the first section of how we organize ourselves so that we can contribute and have opportunities for everyone. And the other way of doing it is the project-based approach, which is one of you might come up with an idea. Let's say I want to start a project about long COVID pain in older adults in nursing homes. So this is my whole question. So I'm going to share with the group who any one of the fellows might be interested in this area. They will jump and tell you, yeah, I want to join your team. So you will be the project leader for that project, that research question. And then let's say a few of the fellows join you. Could be from you or from the senior fellows. So you're gonna work on identifying the next step for that project. So first step, you want to write the method and you want to identify the task. So you can work on that with the team. And then you can say, okay, we have 10 fellows, we have 5 tasks. So maybe we can identify two fellows per each task. So the first 2 fellows will go to the literature, they will look up whatever. The second 2 fellows will do the second part of the task and so forth. So by the end of the project assignment, you will have next is what time frame you want to do that project. Let's say in 2 weeks, we want to collect all the data. After that, in 2 weeks, we want to write the draft if you want to make a manuscript out of that. Or if we want to collect data, then in 2 weeks, we will create the survey or the variable and how we can collect the information, let's say from the job, from patient's job. So you will create a timeline, and then the team in that project will be working according to which will work with which, like that 2 fellows will be working on the first task. As soon as they finish, they report to the project leader. So the second 2 fellows will take it from there. Sometimes they can work simultaneously. Each fellow will be working on one part of the task. So let's say we want to meet the deadline. So one fellow might write the skeleton of the manuscript or the poster or the abstract. Then we can add the information later, like the references, the data, the graph, and so forth. So it depends on how you want that as a project leader. So this is from project perspective. And you can run one project, you can be involved in one project, or you can run more than one project and then also involved in more than one project. So it depends on how aggressive you want to be in this program, as well as how much time you have in your hands. We want you to learn many things. We want you to learn, not only the research part, we want also we want to learn how to be a leader. So leadership, how to organize stuff around, how to manage your time, how to manage a project. All this you can talk about when you have your interview. You will gain some different skills during this program. And hopefully when you have interview, you can talk about, I learned this, I did this, I created this, I participated in this, I was involved in this. So you will have a vast area to talk about. This is the idea of the program. And hopefully the end product will be, you will publish either in the form of abstract that can be poster presented, or you can publish as a paper, or you can do a webinar, or you can do develop an app. So there are different things that you can do and you can add to your resume. So you will be unique candidate for residency when you apply. It's gonna be something to show others that you are different than the other applicant for that program if you are interested. We want to spread this to the graduates from every aspect. So we started with medical graduates. We added dental graduates. We have therapy. So any graduates who wants to do therapy in the US, they want to improve on their clinical skill, not clinical, on their research skill, they can join the program. And in the future, maybe we will add some nursing and so forth. So it's just the program itself is in development as we talk. So this is how the dynamic of this program. It's self-paced, so each one of you, they have their own responsibilities at home if you are married with kids, or if you are busy at work, or if you are preparing for steps or doing this and that. But we expect you to spend some time learning areas that you don't know. The app will help you. We collected a lot of videos there. You can do self-learning. There are some files from the American Geriatric Society. These are the teaching files. The first one that was presented today is one of them. These are teaching slides. So you can pick up one of these and learn about geriatric. So the focus in geriatric, but we are not limited. So some of you might be interested in pediatric. So you can learn about pediatric as you go on your own pace. Some might be interested in neurology or in psych. So the whole process will help you, but we are not limiting you to focus on geriatric. It's better if you are unique and you are needed. So in general, in the US, the number of older patients is increasing. The need for health provider in this group is increasing. So if you present yourself in this area, you will be much, much needed. So you'll have some opportunity. Nevertheless, if you are interested in something else, neurological route, then you will see some of other patients with some neurological conditions, stroke, Alzheimer, or Parkinson, for example. So when you learn this process, you may have some areas that can improve your career in neurology if you know something about geriatric. Unless you want to go to pediatrics, then your geriatric might not be of much help, except for grandparents, for the patients that we take care of. So thank you so much. I tend to talk a lot. So
Thank you, Dr. Nader. It's really great opportunity to further my career. Thank you so much.
Thank you. Any other questions? So now the Bernard mentioned that primary care provider is also needed. And so the number of providers or doctors almost doubled in the last few years. So for instance, when we started the program, my goal is to target applicants, medical graduates who suffered from applying and not getting accepted to the residency. So it's frustrating process. It's time consuming, it's money consuming. And at one point you will say, oh, forget it. But we don't want you to reach that point. So some of the graduates who did all they can, they passed step 1, step 2, even step 3, and they applied, and because they graduated more than 5 years, let's say, the programs will not look at their application. So they will spend money on ERAS, and then it's gonna be wasted because most of the programs will limit the applicant number only to those who graduated less than 5 years, let's say. So we want you to have a way of improving your resume if you are in this group and make connections. Let's say you want to present in one of the American Geriatric Society, one poster. So you will have some opportunity to make connections with either program directors or some people in the program. And if you continue this, you may know some fellows, you may know some residents or program director or faculty. So at least you will have some connections and hopefully they can look at your application beforehand and then they can, from inside, they can push it and see when you reach to the point where they accept or give you an invitation to look at you after they look at your application, then you will have opportunity to talk about this program and other things that you did in your life. So you will show them that you are equipped to start their program and you're going to be an asset to that program. This is the goal of this initially. So we are trying to help you guys achieve your goals. Thank you. So before we end, I'd like to thank you all again for attending. And I'd like to also make sure if you have questions, please let me know. You can reach me via email, text, or call me. Happy to help as much as I can. When you talk between you guys, you can use the WhatsApp and seniors may help you as well. So thank you all for attending and thank you, Dr. Mafaz, for moderating this Zoom meeting. Thank you all again. Hopefully we can see you next week. So,
Happy holidays, everyone.
thank you.
Thank you, Dr. Nader.
You're welcome. Thank you.
Thank you, Dr. Nader.
You're welcome. Bye.
Thank you very much, Dr. Nader.
And thank you so much.